So, good morning, everyone. I'm Louisa, PGY5, and today I'll be reviewing the contemporary indications for the use of ultrasound in urology. First, this morning I'll be giving an overview of ultrasound in general and recent advances in the technology. Then I'll dive into the emerging clinical applications of ultrasound, specifically in urology, and I'll focus on the uses in endourology and oncology primarily. Oh, the uses are much broader than that even so. So ultrasound is a very commonly used initial diagnostic imaging modality. It's a rapid modality that's effective, portable. The equipment is relatively inexpensive compared to other modalities, and it doesn't cause any harm to kidneys, doesn't cause any radiation, so it's quite beneficial that way. In addition to use as diagnostic imaging, ultrasound is also a great guidance tool for therapeutic applications for a number of urologic interventional procedures, such as HIFU, which I will talk about. The basis of ultrasound is that a sound wave is produced by a piezoelectric transducer. This is usually encased in a plastic housing. And then ultrasonic waves, all these frequencies are above the audible frequencies of the human ear, are produced. And typically in medical ultrasound, the frequencies range from 1 to 18 megahertz. These ultrasound tissue then echo off tissues, and different tissues have different densities or acoustical impedances. And these tissues have a differential refraction, reflection properties. And these sound waves that are scattered and absorbed differentially are returned to the probe, which then detects the echo and displays them as a ultrasonic image. And important to kind of understand the properties of the waves and how they change images. So a higher frequency wave will have a shorter wavelength, right, a higher resolution, but because of the shorter wavelength, they have poorer penetration, so poorer, so you can't image as deep in the body, versus a lower frequency sound wave will have a longer wavelength, but a lower resolution. But the other side of that, you get better or deeper penetration, so you can image things that are deeper. And ultrasound image qualities can be determined by the characteristic wave, and there's multiple parameters you can measure it by. So different kinds of resolution, such as axial resolution, your lateral resolution, contrast resolution, and signal to noise ratio are all parameters various studies they'll use to kind of talk about how good the ultrasound is. And the next part of my talk, we're going to talk about all the different kinds of ultrasound there are. So I think a lot of us, certainly myself, when we think of ultrasound, we think of the typical grayscale ultrasound when you stick a probe on someone and that's what you see. But kind of a significant landmark in the evolution of ultrasound technology has been a transition from just static grayscale imaging to real-time imaging, a lot of improved resolution, and a lot of advancements, which I'll talk about now. So going back a little bit first, so historically there's something called amplitude A-mode imaging. It's more really historical interest. I don't think it's ever used clinically anymore, but basically it's actually a one-dimensional ultrasound image that's displayed as a series of vertical peaks corresponding to the depths of structures as the ultrasound encounters in different tissues. So basically the graph is the echoes plotted on a screen as a function of depth. Again, very historical. This is a primordial ultrasound, 1930s, not really used anymore. And as I alluded to, typical grayscale imaging is also called B-mode imaging, which stands for brightness imaging, is what you think of when you think of ultrasound, and a linear array of transducers basically simultaneously scans the planes through the body and displays the acoustic impedance of this cross-section of tissue, giving us our typical ultrasound views. Next, M-mode imaging or motion imaging is something that we all also have a little bit of familiar with, primarily seen in cardiac echoes, and it's a time motion display of the ultrasound wave of a certain part. So very useful in valves, for example, and also lungs for lung sliding to pneumothoraxes, etc. And last one that I think we kind of use day to day in practice would be Doppler imaging. The Doppler effect is used to measure blood flow velocity, which is overlaid on top of a conventional grayscale B mode imaging. There's different kinds of Dopplers, which I won't necessarily go to, but obviously we use this quite frequently to rule out testicular torsions. We use this for transplants to assess perfusion. You can also use this in priaprisms. But the really interesting stuff kind of comes up next. So for tissue harmonic imaging, it's a variation of ultrasound, but instead of producing kind of a single ultrasound wave, multiple higher frequency waves, harmonics of a single fundamental frequency. I'm no physicist, but that sounds fancy. And because there's so many extra waves, the processing that comes afterwards produces a higher quality images where all of the various noise and artifacts due to aberration are greatly reduced. And a big benefit of tissue harmonic imaging is that it's especially useful in obese patients because it decreases a lot of the body wall artifact and it'll improve the lesion visibility. And one of the primary uses that I've seen in the literature for tissue harmonic imaging would primarily be characterization of renal masses, renal cysts. And in the first image up there, where the positive arrow sign is, the conventional images, you don't really see the internal details of the mass very well, versus in the second tissue harmonic imaging, the edges are much crisper. You can kind of see where the architecture changes compared to the normal parenchyma. So it's very helpful in finding a Bosniak classification. The next thing I found in literature was something called spatial compound imaging, and kind of similar to tissue harmonic imaging, but basically the same tissue is imaged multiple times by different directions using parallel beams. And then the resulting echoes from all these different directions of beams are averaged to produce a single compound image, which again is improved quality due to reduction in image noise and image speckle. And again, you can see the top image there is just conventional B mode ultrasound. The bottom with the spatial compound, you can see a lot more crisp edges and contrast differentiation, which is helpful in things like renal masses, again, finding the margins of lesions. Next, we'll talk about 3D imaging. And so 3D imaging, again, uses multiple data sets of 2D images from the patients. And then after acquisition, the volumetric data is post-processed with use of many analysis tools, volume rendering, multiplane imaging, and then all these features in the data sets are registered to form a final 3D rendered display of tissue structures. And when you do 3D ultrasound and this image is displayed over time in real time, this technique is called 4D ultrasound. And a big advantage of this is you get a lot of improved spatial orientation instead of something 2D, you get the whole 3D view. And it's also said that has improved accuracy for repetitive assessments as well, because it's not as dependent on which exact plane you're doing. And you can see the first image, again, conventional grayscale, and the bottom image 3D. So the kind of the sphere of the bottom is actually a Foley balloon, which you can see very clearly. And the cool part is at the top of the image, that little ditzel is actually a bladder tumor at the bladder dome, which you would never be able to see with conventional ultrasound, but that is clear as mud there. And another mode of ultrasound that's kind of up and coming is contrast enhanced ultrasound. There's two basic elements of this. One is the ultrasound contrast agent, and two is the contrast specific imaging mode. The contrast agent is actually kind of a microbubble of mostly insoluble gas. The first generation could be agitated saline or hydrogen peroxide, but the and the contrast agents now are typically gas that are stabilized with a phospholipid or albumin. And basically, as the gas gets exhaled, the shell gets metabolized in the liver. And once these contrast agents are injected into the venous circulation, the region of interest is imaged using a specific ultrasound mode. And the interaction takes place between the ultrasound beam and these microbubbles in the circulation and generates a very clear image. So the primary uses of contrast enhanced ultrasound are to assess the perfusion of tumors, because you get a washout essentially like you would for have a washout CT, which is pretty cool. And they'll often use this to image renal cysts or sometimes renal tumors, distinguish pseudotumors from real masses, and you can look at ischemia as well. And I'll talk about this later, but sometimes they'll use this to aid in interventional procedures like RFA. A couple more modalities to go through. The next one is ultrasound elastography. It's a relatively new modality that maps the elastic properties of soft tissue. It kind of quantitatively images the tensile modulus or elastic modulus of a tissue, which is essentially the stiffness or elasticity of a material. And this non-invasive technique is almost like a digital DRE. The deformation of tissue to kind of a small applied pressure is measured. And this external force could be static or dynamic. That's a sort of digital DRE. And this is all generated by the probe. And aside from measuring in the prostate, there's potential for this to be used, for example, in renal transplant. The native kidneys are way too deep in the body for this to work, but a renal transplant, because it's more superficial, can be potentially used using the elastography techniques. The differential in stiffness could potentially be used to see whether there's a likelihood of rejection. It could potentially help determine whether a patient needs a biopsy or not. All right, fusion hybrid imaging. Beyond the scope of this talk to dive into deep details about this, but there's extensive literature on multiparametric MRI with ultrasound fusion targeted biopsies, especially compared to conventional chest biopsies. But beyond the scope of this talk to go too deep into this, and we're all somewhat familiar. And finally, there's endoluminal ultrasound, which is basically a ultrasound in a very small catheter, 5 or 6 French. These catheters are designed that they can go over guide wires, and once in the lumen of usually the ureter, plus or minus at the junction of the UPJ, you get a 360-degree cross-section of the structures and tissues, which conveys a lot of information about the spatial relationships of anatomic structures, which I'll chat about. So a whole lot of different technologies. Let's go through the clinical applications and the literature I was able to find for specific applications. So we often will get referrals for ultrasound showing stones, and in conventional BEMO imaging, it's just a little bit of posterior acoustic shadowing, plus or minus hydronephrosis, which tells us stone. Often a not very good image and very subject to size discrepancies. There isn't a ton of publications about this, but it's thought that tissue harmonic imaging, because of the increased detail you get, there's more prominent posterior acoustic shadowing, which is one of the main ways you see stones. And they actually thought that using in this one paper, using a regular plain film KUB plus a THI ultrasound was almost comparable to a plain film CT KUB and identifying with renal and ureteric calculi, which is pretty interesting. And the next thing we'll talk about is UPJOs. So this catheter-based endoluminal ultrasound can give you a lot of detail about what's going on. It's not so much used intra-op, but it's used in the diagnostic evaluation to determine, what's causing this UPJO, and you'll see that it could be quite useful. And then there was a study that looked at whether using endoluminal ultrasound ultimately changed what people were going to do, as in, are they going to do a pyeloplasty versus an endopyelotomy, or is there something else like a cancer that needs to be done? And it actually changed the interventional procedure. They ultimately chose in almost 20% of the cases, which I think is pretty significant. 1 out of 5 cases it changed. So the first image here, so use the long horizontal probe is the endoluminal ultrasound probe. And in the study, so all these people were referred for core UPJOs, and on endoluminal ultrasound, one person was found to have a stricture. The second image here shows actually submucosal calculi causing a bit of narrowing, bit of obstruction, which I think you'd be kind of hard pressed to see using other modalities. And the last one, which I think is quite significant, is that this so-called narrowing was actually a big upper tract mass, which obviously the management would be quite different from doing just a pyeloplasty for non-malignant reasons. I think next, the biggest use of one of the biggest uses of ultrasound and urology is ultrasound guided access PNLs. Typically, our Stone Center, and when Dr. Chu and Dr. Patterson do this, is primarily using fluoroscopy, which is kind of the typical technique that we people use, but ultrasound guided access is something that's increasingly being used. Basically, intraoperatively, the renal image is taken is beam imaging using a abdo curvilinear ultrasound probe. Frequency is 3.5 to 5 millihertz, and then you can puncture using 2 ways. The longitudinal needle enters from the top or the bottom of the probe, or the transverse technique where it enters the side of the probe. The transverse technique is slightly more difficult because the needle is only seen in a single cross-section as it advances towards the target. But there are a number of studies that suggest that really ultrasound-guided PNLs and fluoroscopy-guided PNLs are both pretty much equally as safe and as effective in experienced hands. This is actually a very large review of 12 articles, including 6 randomized controlled trials, as well as 3 meta-analysis. And the global conclusion of this review was there's no difference in the success of actually obtaining the access, which I think is quite impressive. No difference in bleeding and blood transfusion, no real difference in operative time, no difference in post-operative complications, and no difference in hospital length of stay, which is very impressive. And the other thing is that in addition to not having any kind of clinical disadvantage, you actually get the advantage of you get significantly decreased radiation time. And what I thought was interesting was that there were actually 2 different papers that specifically looked at the learning curve of getting into ultrasound guided access versus fluoroscopy. And they estimated in this particular paper that you need over 100 cases to get really comfortable with doing a fluoroscopic guided puncture, versus for ultrasound guided access, people were, reasonably obtaining access by about 20 cases. And because this learning curve is a little bit shorter, in another study, they looked at the fluoroscopy time, and within the first 15 cases, they report you can reduce your fluoroscopy time by 75%, which is obviously quite significant for the operators, all the staff in the room, as well as the patient themselves. And final thing is for ultrasound guided access, perhaps one of the reasons why the learning curve is a little bit shorter is it can actually be easier to select the optimal calyx, which is often a posterior calyx, which is right there when you put the ultrasound needle. It just often happens to be the most easily selectable calyx. So that might be part of the ease of learning ultrasound guided access. And ultrasound guided access has been validated in several different populations. One, spinal deformities from congenital um, issues, or in pediatrics as well. And you can do ultrasound guided access prone and supine. Most of these are single center prospective kind of proof of concept papers, but it has been reported as literature that you can totally do this and safely. And something that's maybe going to be even further improving ease of access of ultrasound guided PNLs is targeting. So there could be sensors in the needle and on ultrasound probe. A couple, again, proof of concept studies in the literature, but there's one looking at electromagnetic guidance with a sensor actually in the needle and on the probe, and the imaging system would show the needle and its predicted path on the screen, which kind of makes it quite dummy proof. And there's another study that looked at optical guidance. The outer part of the outer part of the needle is tracked, and again, the computer program predicts the needle's path, which is simulated on the screen. Even though this seems really great in theory, one of the problems is that the needle will bend inside the patient, so the predicted path will not necessarily be the actual path. But no matter what kind of access you're doing, the needle will bend inside the patient. So to some degree, you do have to account for that regardless. Okay. And kind of the last thing I'll talk about specifically in urology is in terms of uroscopy and stenting. There's a lot of thoracoscopy, and then usually not that much of a consideration until you're talking about somebody who's pregnant, for example, and you really want to minimize radiation. So I kind of looked into the literature, and there's not really any even proof of concept papers about the idea of using just ultrasound, and no thoracoscopy at all in these retrograde cases. There is some suggestion that you can try using ultrasound to produce image the proximal coil and position that, but it's a very small stent. It's not that it is radio opaque, but it's hard to see. So long story short, unfortunately, ultrasound's not really a good replacement for just a regular run-of-the-mill uroscopies, despite all these various advances. All right, so we'll shift gear now a little bit and review the literature on the current clinical applications of ultrasound in oncology specifically. And, traditional B mode, again, Doppler sonography have been the mainstay of GU tract imaging in many years in general, in most centers as the imaging modality of choice, and still is. And a lot of these emerging clinical applications aren't widely used. And I don't think it's necessarily because they're not effective, but because of institutional limitations in acquiring the necessary bits of equipment, really. To use these. So in bladder cancer, there's a number of groups that have tried using contrast enhanced ultrasound, and they found that high-grade tumors and low-grade tumors have very typical and distinct enhancement patterns for this contrast agent. Low-grade tumors, you can see on the curves on the screen, have a very slow wash-in but fast wash-out, versus higher grade tumors seem to have a characteristic high grade wash-in versus a slow washout. And even though both and all these cancers are kind of hypervascular, these differential specific perfusion parameters can be helpful in differentiating the different grades of tumors with a pretty high sensitivity and specificity in this one trial that looked at it. And again, looking at the curves, they do look quite different. So I can see how that would be helpful in differentiating the grade of the tumor. And also in the bladder cancer world, 3D ultrasound has been looked at a lot. And in this one study for kind of run-of-the-mill hematuria workup, they found that certainly 3D ultrasound was far better than 2D ultrasound in identifying the tumors, and then, which is kind of a intuitive conclusion, but they went further, and they looked at what they diagnosed on 3D ultrasound and compared it with cystoscopy, and it was remarkably close to what they saw endoscopically. And I will and it was remarkably close in terms of multiple things, in terms of location, size, and morphological features. And I'll show you some cool pictures from the study. So the first thing in the first set of images on the left side is this bulge there. That looks like it could be a bladder tumor, but on the image to the right of that, the corresponding 3D images, you see that it's actually just a really big median lobe of the prostate that was imaged at a funny angle on the grayscale image. On B, there is a cystoscopic image of a papillary tumor. This tumor is on the trigone, and on the 3D ultrasound, you can see a little bit of a ditzel on the trigone, which corresponds to this tumor. And the last image I had shown earlier, but you can appreciate that there is a tumor at the bladder dome, which I could not see on the simple grayscale images. So lots of potential for imaging, but of course you need specialized equipment in order to be able to do this. And for upper tract urothelial carcinoma, endoluminal ultrasound, I think, also has a lot of potential. A couple of papers looked at the concordance of staging with endoluminal ultrasound during diagnostic uroscopy with the final pathologic staging. So basically, most of these people ended up getting a nephrourectomy, plus or just a biopsy, but most of these people went on to get something more. And they found that for non-muscle invasive disease, there was slightly better accuracy versus muscle invasive disease. Obviously, more studies and perhaps better instrumentation are needed before this is incorporated into practice. But for upper tract, that's notoriously poor concordance of your diagnostic uroscopy findings with your final staging. So I think this is actually not bad, all things considered. And moving on to prostate cancer, there's also a lot of studies looking at contrast enhanced ultrasound guided targeted biopsy. Has not gotten as much traction as fusion biopsies, but there are two papers that reported there was an increased detection rate of prostate cancer using contrast enhanced ultrasound compared to just systematic biopsy. Interestingly, only increased detection rate in the peripheral zone, but not the central zone. And the idea of this whole thing was that prostate cancer nodules tend to show early enhancement after the administration of the microbubbles, the contrast agent, due to the increased vascularity, thus the guided biopsies. And another thing was the elastography. And I only really found one single center prospective study. There are 53 patients showing elastography. And the idea here is that the prostate cancer nodules have a different tissue stiffness compared to the benign tissue around it. They reported that for malignant lesions, the elasticity was kind of in the range of 30 to 100 kilopascals, compared to benign lesions with a range that admittedly was a little bit of an overlap, but the mean value was lower. And they found that that could somewhat help differentiate. But the problem is that there were a lot of false negative biopsy rates based on just elastography in the study, because the values for the elastography basically overlap. So has not gotten that much traction because of that. A lot of false positives because various differences, and even benign tissue like a prostatitis calcification or BPH nodule will change the elasticity, and smaller tumors or a softer malignant nodule or a larger tumor will all kind of change the elastography measurement. So all in all, probably not that valuable. And I think I've only have one slide on this because again, this is a huge topic, and we've talked about literature and various other journal clubs and grand rounds as well. But this one systematic review reports that multi-parametric MRI ultrasound fusion biopsies versus the standard 12 core almost certainly detects more clinically significant cancers. And a number of cancers that would have been missed by just systematic biopsy are kind of found on the fusion ultrasounds. And the other thing is that a lot of centers have moved away from doing systematic plus a target biopsy. So because you're only doing the target biopsies, you can use fewer cores. And the last thing I'll talk about for ultrasound is HIFU. Essentially a transrectal high-intensity focused ultrasound probe that generates ultrasound wells is used to thermally ablate prostate tissue. So it's an ablation technique, and you can do partial or total prostate gland ablation. I saw a lot more literature on partial gland ablation, and kind of a little bit concerning to me that this technology actually failed FDA approval for prostate cancer specifically due to the inability for anybody to really demonstrate a direct patient benefit in the literature. Subsequently, FDA approved the HIFU technology in general for tissue ablation, period, but not really specific to prostate cancer. But obviously, people have been using it and trying it for that application. And the literature isn't very strong, not enough to get FDA approval because it's really only single arm prospective cohort studies. There's no RCTs at all, except for a feasibility to study that looked at whether it would be feasible to perform an RCT, which has not been done yet. And a lot of these studies will look at with or without prior TURP because it kind of changes efficacy a little bit. And I think the biggest limitation in a lot of these studies here, again, it's not a randomized controlled trial at all, but prostate cancer is often multifocal, and with partial gland ablation or these targeted therapies, you end up often missing some sort of prostate cancer or some location of it, which ends up in requiring salvage therapy afterwards. But really, I think it's primarily the absence of comparative and long-term trials that prevents HIFU right now as being considered a first choice. And kind of the best study I found with all this was they looked at not just HIFU, it was HIFU and cryoablation, but it's all partial gland ablation compared with robotic-assisted radical prostatectomy. And not surprisingly to, I think, any of us, that partial gland ablation, whether it's HIFU and cryo together, was associated with a much higher risk of salvage treatment compared to just primary RALPs. It also showed a lower probability of salvage treatment-free survival, but it was associated with a better continence rate. So a lot of people, I think a lot of patients, the reason they'll go for HIFU is that it actually is established in the literature that it probably gives you better potency in continence, which is better preserved afterwards. But I think you take one look at this Kaplan-Meier curve of the it basically shows over time how many patients needed a salvage something, mostly a salvage prostatectomy. And there's I think it's pretty unequivocal that partial gland ablation is inferior to just a first-line prostatectomy in this particular study. And there is another study that looked at, okay, all these people who get HIFU, are they still going to do okay after they kind of inevitably get some sort of salvage therapy? And what they found was compared to a primary route versus a salvage route, you actually get a similar oncologic outcome and a functional outcome afterwards. But because the surgery is much harder. Things are stuck. Things are just not quite as smooth. You end up with a higher rate of complications. Specifically, they report a higher rate of Clavin did know 3 complications, which are significant ones. And the one that was most common in this study was lymphoceles that actually required drainage. And another study, again, kind of worrisome for HIFU, was that after HIFU, they went and did a systematic control biopsy on all of these patients regardless. And 1/3 of these patients actually still had prostate cancers. And most of these, of 30%, it's not that the partial gland ablation didn't ablate. They missed something outside of the field. Most of these people with clinically significant prostate cancer on the biopsy actually had in-field recurrences post partial gland ablation, which is concerning. And many of these people ended up requiring retreatment. The median time to retreatment was just under 3 years. And the last thing I'm going to talk about is contrast-induced ultrasound for renal cancers. And the diagnostic accuracy is quite a bit better than the unenhanced ultrasound for these focal lesions. And one of the helpful things is that RCCs have a very heterogeneous hypervascular, and with a contrast agent, you can get a early washout on the delayed phase, and that's helpful in seeing. And based on a criteria for one of the European ultrasound associations, they said if this mass has an enhancing pseudocapillary round lesion with an early washout, based on these criteria alone, they imaged almost 600 patients, had 100% sensitivity, only 3 false positives, which is pretty good for an ultrasound with 0 radiation. And it's easy to differentiate against AMLs because they enhance peripherally and show less central enhancement. And this is kind of the only sort of guideline I found really about the use of any of these newer ultrasound modalities clinically. And this is one that suggests a possible pathway for looking at lesions, which will include contrast-induced ultrasound. And again, this is just a image for you to look at the top versus the bottom, the difference between how much a contrast-induced images can help you see the difference in what the mass looks like. And this specific study looked at how the tumor was visible before and after the ablation of renal masses and its feasibility for use of follow-up post ablation. And in both for post 24 hours or post 6 weeks after renal ablation had a relatively good concordance with CT MRI. And again, with 0 radiation, a pretty good alternative, I would say. And the last thing is a lot of studies looked at whether contrast-induced ultrasound could actually help guide RFA, mostly very small studies, proof of concept as well. But that's probably something for the future directions to be used. Not yet fully validated, as I said. The benefit of it is that the residual tumor can be recognized shortly after the initial ablation, and then without having taken anything out, you can immediately retarget and reposition the probe and redo ablate the tumor. But again, not fully validated or tested out yet. So with all that, ultrasound has a lot of potential, and a lot of it is based on quite fancy equipment that you wouldn't necessarily be able to get at every center. But I wanted to actually quickly talk about some handheld devices that people could use in clinic on the board. And I think our clinic was looking at one of these 2 devices. I'm not sure which one we landed up on, but there's kind of 3 main ones on the market. One's called the Butterfly IQ, and with all of them, They'll connect to a iPhone or an iPad via a USB connection. They'll run on iOS and Android. Most of these devices require internet connection intermittently, and it's really not that expensive. It's $3,000 for the probe. And then you do need a subscription for certain functions like cloud storage, for example. Oops. The Philips Lumify is probably the most expensive of the handhelds I found. The probe is $10,000. Again, it's a wired USB connection. You can actually share a real-time imaging via the app if you were trying to consult with somebody and be like, hey, what do you think is going on? And Clarius is a local company. It's a Canadian company that's based in Burnaby, actually. This is the only probe that's wireless. And again, you can do real-time sharing via video link. And the probe is $6,500, which is not that much money. And last thing is, she's working on a breakwave trial, and it's basically changing the frequency of waves to break up stones. And there's a trial that's ongoing here, and conveniently also a trial going on in Queensland, where I'm headed to next year. So that's other things that are up and coming with ultrasound technologies. So in conclusion, ultrasound is a really integral part of the diagnostic armamentarium in the practice of urology, with some emerging therapeutic applications as well. And these advances really could be playing an important role in urology in the future. So thank you. I am happy to answer any questions now.